Dear all, welcome to this new webinar. It's the fifth one of this series of the webinar organized by EUROGEN, OMNI-NET, International Federation of Spina Bifida, and other European reference networks that are supporting us. Welcome, and I'm Giovanni Mosiello, and I would like to introduce you Dr. Zimak, please.
Доброго вечора, шановні друзі і колеги. Ласкаво просимо вас на четвертий до участі у четвертому вебінарі спільної серії, яка Україна-ЄС про спінальні дизрафізми. Організована ERN-EUROGEN, OMNI-NET Міжнародною благодійною мережею OMNI-NET для дітей Україна та Міжнародною федерацією Spina Bifida та гідроцефалії. Для тих, хто до нас приєднався вперше, нагадаю наші правила. Кожен, хто відвідує цей онлайн-вебінар, отримає сертифікат участі. Також учасники будуть мати можливість отримати бали міжнародної акредитації, якщо вони заповнять опитувальник, який з'явиться після закінчення цього вебінару. Ті, хто пройшов опитування, отримають сертифікат з міжнародним балом орієнтовно через 3 тижні після закінчення нашого вебінару. Маємо спеціальне застереження для української аудиторії. У разі, якщо звучатиме сигнал повітряної тривоги, просимо вас негайно спуститись в укриття. Перегляд запису, відповіді на питання будуть доступні згодом. And now, Professor Musiello.
Yes, thanks, Dr. Zimak. And yes, as Dr. Zimak explained, you can obtain a certification for this webinar, you can obtain credits, and you can send your question, and also after the webinar, and of course during the webinar. And now we'll go to answer to the question of the previous webinar that was held on the topic of neurogenic bladder classification. And this is the system that we decide together. So please remember, question during the webinar and question after the webinar. And you will find all also on the website. There was a question about the codification of neurogenic bladder. As you can see, we have a specific code for neurogenic bladder, and then we have other code for specific condition as bladder paralysis, hypertonicity of the bladder that is related to the overactivity, to atonic bladder, low bladder compliance, incomplete bladder emptying, and incontinence. Please remember that we don't have a specific ORFA code for classifying neurogenic bladder. We have 2 ORFA codes that are related to non-neurogenic bladder, that is Inman syndrome, but is different, and to Ochoa syndrome. So not to do confusion, because it's very important that at the moment, if the question is there is an ORFA code for neurogenic bladder, the answer is no. We have other question, and what to do when urodynamic is not available for clinical classification neurogenic bladder. When urodynamics, or better, video urodynamics is not available for diagnosis of neurogenic bladder INSA classification, is related to what? To clinical signs, type of urinary incontinence, urgency, frequency, retention, and diaries and questionnaires are useful in order to understand what you are going to observe, and also helping patients and families to define the pattern of their bladder. It's important to observe micturition. It's important to have indirect diagnosis of neurogenic bladder. And for this, ultrasound is useful because you can observe hydronephrosis, you can observe post-void residual, you can measure bladder wall thickness. Again, if you have an X-ray, you can perform a void in situ retrogram, and in order to observe reflux, to observe the bladder profile, to better define diverticula and the profile of the bladder, and to observe the bladder neck during the filling and the emptying. Furthermore, you have to consider the type and site of spinal lesion, suprapontis, subpontis, supraspinal. As you, Professor Nijman, we are going to explain today, you have to acquire either the skills to perform urodynamics, but you have to acquire urodynamic mind. Next question, please, was related to the neurogenic bladder and spinal cord injury. In spinal cord injury, it's most common to observe neurogenic detrusor overactivity and detrusor sphincter dyssynergia. While in the spina bifida, it's common to observe lower lesion, in the spinal cord injury, it's possible to observe higher lesion, cervical and thoracic lesion. For example, children involved in a car accident, it's common that they can present cervical lesion. And this is important to remember because there are different populations, spinal cord injury and spina bifida or spinal dysraphism. Furthermore, if you have a spinal cord injury with a high lesion above T6, there is a risk for autonomic dysreflexia, with the risk of cardiovascular complication, either in daily life, but either during urodynamic evaluation during bladder filling. Other question was referred when to repeat the urodynamic. First of all, you have to consider European Association Urology guidelines. At the moment, we have guidelines for pediatric urology or guidelines for neurogenic bladder. In guidelines of pediatric urology, there is a very complete timetable when to perform urodynamic evaluation. Now, thanks to the support of Professor Nijman, that lead this working group, this subgroup for working group on the guidelines, we will have specific guidelines for spina bifida with a more precise timetable. Normally, in order to observe a treatment effectiveness, 3 months could be enough. Other question has been referred to oxybutynin treatment, when to stop before urodynamic. It depends, it's related to the aim of urodynamic evaluation. If you need to confirm the effectiveness of the treatment, you can't stop oxybutynins. Otherwise, in order to observe a native urodynamic pattern, it's better to stop 2-3 days before urodynamic. Of course, you have to consider the risk for the upper urinary tract. You have to consider the compliance of the patient. What does it mean? That if you have a high risk situation, it's better to stop only 2-3 days before. If you have a safe situation for upper urinary tract and you believe that patient families need more days, you can stop before. Very important to remember is the life of oxybutynin, because you have to administer oxybutynin every 8 hours, so 3 times per day. Regarding Mitrofanov indication for Mitrofanov are mainly related to privacy and independence of the people, especially in female paraplegic patients, in order to facilitate clean intermittent catheterization. Other people that can gain advantage from Mitrofanov are wheelchair-bound patients, patients with a sensitive urethra. That could be the case in patients with tetracord only, and when there is a urethral stricture. Other point to consider is the ability of the patients, the mental status. Why? Because in some cases could be useful to create a Mitrofanov stoma. In other cases, maybe could be useful to consider other choice, other acystostomy. We receive other questions that are related to the alternative to clean intermittent catheterization in the future, and what are the works for this actually. And we know that some results are coming from reinnervation, is the Dexiao procedure, but actually there is no demonstration that there is effectiveness in the long term. So this is totally experimental, and you can't recommend this for your patients. And other solution maybe could be in the future for sacral neuromodulation, but again, we have very few data, and in the personal experience, we can say that spina bifida patients are not the best candidate for this kind of treatment. For at the moment, the answer is that we don't have an effective alternative to clean intermittent catheterization. Regarding the papers comparing early and later clean intermittent catheterization in spina bifida, and you can find paper, different paper in European guidelines, and in my opinion, one of the best paper is a paper of one colleague from Netherlands, Peter Dick, that in 2006 published a paper in European Urology on early start to therapy preserve kidney function in spina bifida patients. And it's very useful and very interesting. So my suggestion is to read it. Peter Dick, first author, European Urology, 2006. I believe that we answered to all the questions, and I believe I would like to leave for comments to Dr. Zimak, please.
Thank you, Professor Musiello. Thank you very much, and Professor Rien Nijman for your answers and comments. And I have one small question. Do you use ICD-10 classification? Because now in Ukraine we use this version of ICD-10.
And it depends about the national system. Actually, in Italy, we are using ICD-9, and in some center are using ICD-10. So, of course, the work are in progress, and our aim is to be able to produce with our European working group a specific codification in ORFA code, because could be useful. As you heard in the previous webinar, we have worked on the classification on the spinal dysraphism, spina bifida, and one of the objectives in the future will be to work on the classification of neurogenic blood. Thanks.
Thank you very much. Шановні колеги, хочу повторити, що відповіді на ці питання ви прослухали зараз, і так само будете мати змогу прочитати їх на сайті ERN в рубриці Past Webinars. Хочу також нагадати, що ви маєте можливість задати питання доповідачам. Якщо ви берете участь в прямому ефірі, ви можете поставити питання за допомогою опитування. Відповідь ви отримаєте пізніше. Якщо ви переглядаєте запис на Ютубі, то також можете скористатись розділом коментарів. Або надіслати електронний лист на адресу, яку ви бачите на екрані. А зараз... Professor Musiello.
Yes, please consider that if you wish to ask a question regarding the presentation today, you can do so typing it in the question box. Some of the questions will be addressed in the webinar today. And you can submit questions after the webinar, and these will be answered at the beginning of the next session, as today we are doing for the previous one. Question we will also publish on the eUROGEN website.
Дякую. А тепер я маю велику приємність представити нашого сьогоднішнього спікера, з яким ми мали можливість познайомитись і на попередньому вебінарі. Спікером сьогоднішнього вебінару є професор Rien Nijman, дитячий уролог з університетського медичного центру Groningen у Нідерландах. І сьогодні ми більш детальніше проговоримо про уродинаміку.
Thank you. Yes, thank you, Dr. Zimak. Now it's time for the webinar of today, and we are proud to introduce Professor Rien Nijman, pediatric urologist, professor of urology in Groningen in Netherlands, and he is the chair of the European Office for Continuous Medical Accreditation in Urology. He was chair of the ICI panel for pediatric incontinence, and he was very precious in order to produce with his contribution the new guidelines, urological guidelines for spina bifida.
Professor Nijman, please, the floor is yours.
Well, good evening again. Last week we gave the first webinar on the categorization of neurogenic bladder in patients with spina bifida, and we also mentioned the importance of urodynamics in order to do that. Today we will have a webinar only on urodynamic investigations in children. I told you already that I used to work in Groningen, which is in the northern part of the Netherlands, and I still have no disclosures, except that I'm also working in a working group, and we have just finished preparing, we're still working on it a little bit, on the management of neurogenic bladder in patients with spinal dysraphism. So the topics that will be discussed here are listed: uroflowmetry, cystometry, video urodynamics, just a couple of slides on pressure flow studies, urethral pressure profile, and ambulatory urodynamics. Now, in order to have a more standardized protocol for how to do urodynamic studies, the International Children's Continence Society published a standardization report on urodynamic studies of the lower urinary tract in children. That was a couple of years ago. It was published in Neurourology and Urodynamics. I would recommend, if you are not too familiar with this particular topic, to have a look in the journal and read this standardization report. It's really, really very helpful. Now, just a few slides on uroflowmetry, and I'm fully aware that most children with a neurogenic bladder don't avoid voluntarily. They're usually treated with CIC, but some of them do avoid spontaneously, and then sometimes it's helpful to do a uroflowmetric study. When you do record the uroflow, you look at the volume, the voiding time, voided volume, the maximum flow rate, and this all depends on the voided volume, the trussal contraction, and whether or not there is any kind of outflow resistance. Mostly in adults, we look at the maximal flow rate because that will help you in diagnosing adult patients with urethral strictures or other forms of outflow obstruction. In children, we usually look at the shape of the curve, and this pattern contains most of the important clinical information. As I said, in children with MMC, it is of limited use. It cannot diagnose the cause of impaired voiding. You should always do it in combination with the determination of residual urine. And you can also, if you don't have a flow meter, just take the child to a toilet, listen and watch the child void. That will also give you some useful information. This is a setup that we have in our hospital, a flow meter in a chair, the bladder scan to determine residual urine, and some wooden blocks to support the child when it is sitting on the chair. Because if the child is sitting in an unstable position, most of the times the pelvic floor muscles are activated, and that will automatically influence the shape and form of the curves of the flow. So this girl is almost disappearing into the flow meter. She's struggling to sit upright, and that gives an interrupted flow pattern. The flow stops once in a while, and when she's sitting with good support of their feet, she's in a stable position, and then you can have a reliable normal flow. These are some of the patterns in children. Normal flow, that's a bell-shaped curve. Staccato pattern, when there is, for instance, dysfunctional voiding with intermittent contractions of the pelvic floor muscles, an obstruction in case of a stricture, for instance, and a completely interrupted curve. And I will show you some examples later on, because if you have a flow pattern like that, you don't know whether there is any kind of detrusor contraction or not. You can also combine it with pelvic floor EMG, and that is sometimes helpful, especially in children with dysfunctional voiding or DSD. During the cystometry, there is a filling phase, that is the static part of the study, where you look at cystometric volume, whether there's overactivity of the detrusor, and you can see whether there's a normal compliance or not. During voiding or leakage, especially in MMC patients, you look at the detrusor pressure during voiding and leakage, whether there is good contractility, normal detrusor contractions, and that will also give you some idea about outflow resistance. We always combine it with a pelvic floor EMG to give you some idea about pelvic floor muscle activity. But you have to be aware that a urodynamic study in any child is not a natural situation. The room, the environment where we do the studies for any child is quite abnormal. There are people around. Most of the children are quite anxious, especially in the beginning of the study. They are not used to having a transurethral catheter in the urethra. The filling rate has to be slow, and the water temperature, or if you use contrast medium, should be of body temperature. This is a slide that you have seen last week as well. More than 40 years ago, it was clearly established by McGuire in the United States that when there is a high pressure in the bladder, and he determined the detrusor leak point pressure above 40 centimeters of water as the cutoff point, that was associated with reflux and renal damage. And there was a significant correlation. And so those are the parameters that we look for in the neurogenic bladder in children to determine whether there is a danger zone during the filling phase, where the kidneys are really at risk. So in general, when the leak point pressure is more than 40 centimeters of water, there is a high risk for the upper tracts. So what do we use? We use a water-filled system, and we fill the bladder with contrast medium doing video urodynamics. It's a double lumen catheter. There are different sizes, somewhere between 6 and 7 French. We use a rectal feeding tube to measure the pressure in the rectum, and some skin electrodes on the pelvic floor. And on the right, you can see our setup. You can also use a microtip transducer. Here, the transducer is located in the tip of the catheter. You can fill and measure the pressure at the same time. And this has some advantages, but it is a more expensive way of measuring the pressure in the bladder. If you use a water-filled system, the pressure actually is measured outside the body. Here you can see a little girl sitting on a flow meter in front of the X-ray machine. She looks quite happy. And at the right, you can see the people responsible for the fluoroscopy sitting behind a screen. Most of the time, the parents are present, and we also let them watch a DVD or a videotape. This is a more modern setup, but as you can see, this is for any child, not a very pleasant surrounding. So you can imagine that some anxiety always is present. We start with a free flow and measurement with residual urine, which is quite easy because you have to insert a catheter anyway. You do 2 or 3 filling and voiding phases. We use fluoroscopy and a pelvic floor EMG. As I said, the parents are usually present. The child can play a DVD or a video or whatever. Most of the times they now bring their own iPads, and that is all to distract the child a little bit and make the child feel more at ease. The filling rate is somewhere between 5 and 10% of expected capacity per minute, so that's really slow filling. And actually, it's quite a bit slower than in the adult patients. You can use several formulas to calculate expected bladder capacity. A simple one is the H+1 times 30, but it is much better to base the expected bladder capacity on the voiding diary, or in case the child is on intermittent catheterization, a list of times and portions of CIC. This is a normal urodynamic study. At the top, you can see the pressure measured in the bladder, the PFS, then the rectal pressure, abdominal pressure, and you have to subtract the rectal pressure from the abdominal pressure from the bladder pressure to have a good understanding of the detrusor pressure. Then this is the flow curve, the pelvic floor EMG, and you can see that there is perfect relaxation during voiding. And at the bottom, you get an idea about the filling volume as well as the voided volume, so that you can calculate the residual urine. Now, this is just an example of the same patient where we changed the filling rate. And at the top, you can see that the filling rate was 20 mL per minute, and that during filling, there is a steady increase in pressure. And that means that the compliance of the bladder is quite poor. When you reduce the filling rate to, let's say, 10 or 15 mL per minute, you will see that there is much less increase in pressure during filling. There is still increase, but much less, and therefore the compliance is much better. And that is especially of importance in patients with a neurogenic bladder, that you have to be very much aware of this. Here you see an example of a child with pelvic detrusor overactivity. And every time the bladder contracts, there is also contraction of the pelvic floor muscles. And when there is an extremely strong detrusor contraction, you can still see that there is no relaxation of the pelvic floor muscles. And after some time, there is some voiding, but you can see that there is voiding with high pressures, and there is incomplete relaxation of the pelvic floor, and there is some significant residual urine. And that is the case in detrusor sphincter dyssynergia. This is an example of two filling phases in a child that was, during the first filling, extremely anxious. And you can see that at low filling volumes, there already is bladder overactivity, detrusor overactivity, and detrusor contraction. You can see that there. And then during voiding, there is at first no relaxation of the pelvic floors, and later on it goes well. But when you do a second study, and I would advise you to do at least 2 filling and voiding phases in every child, you can see now that the child is less anxious. You will see less overactivity. And when she has a full bladder, wait a second here, you can see that there's prompt relaxation and voiding with no residual urine in this particular case. Now, in those cases where the detrusor does not prompt to a relaxation of the external sphincter or even the internal sphincter, and that is always difficult to determine, there is dyssynergia between the bladder contraction and the pelvic floor relaxation. And this is what you can expect. Now, if you don't have a pelvic floor EMG, then video urodynamics is better, because during the fluoroscopy, you can see whether there actually is relaxation of the bladder neck and the external sphincter, especially when voiding occurs with extremely high pressures, like you can see in this case, where the compliance is diminished and there is extreme high pressure in the bladder during voiding. In this particular case, you can see that there are strong detrusor contractions. Every time the detrusor contracts, there is contraction of the pelvic floor muscles. And at some phase, when the pressures overcome resistance, there is a little bit of avoiding. And I put avoiding in between brackets because this is not what we call real voiding. This is a contraction leading to leakage. Some examples of neurogenic overactive detrusor. Well, they are all familiar now. So the basic question is, how long and at what volume can the bladder store at a safe low pressure? And this is a slide I presented last week as well, and especially the overactive detrusor with an overactive sphincter. That is what is very dangerous for the upper tracts. Also, overactivity of the sphincter or isolated overactivity of the detrusor are dangerous for the kidneys. And the same is true for urinary incontinence. So the most dangerous situations are when there is detrusor sphincter dyssynergia, but also overactivity of the bladder an overactivity of the sphincter are things that we need to look at. Now, if you have a flow pattern like this, the question is there any kind of detrusor action? And when you look at the urodynamic studies, you can see that there is no activity of the detrusor whatsoever during voiding. And leakage or voiding only occurs with abdominal pressure increase or with straining. So this is an example, not in a neurogenic bladder, but this was a patient with a situation of the valves where there was a completely underactive detrusor. But it may happen in children with a neurogenic bladder as well. This is the flow of urodynamics that I showed you before, and this is an example of detrusor sphincter dyssynergia. And this, of course, you can see that in this 9-year-old boy who was complaining of urinary incontinence, you can see that the compliance is impaired. He voids with extremely high pressures, while there is good relaxation of the pelvic floor. So the most likely diagnosis in this case would be a urethral stricture or any other kind of outflow obstruction. You can also combine this in the pressure flow curve, and sometimes that is really helpful. You can see that there is a very low flow with extremely high detrusor pressure. So I hope that it is clear now that the use of video urodynamic studies is extremely helpful in children with a neurogenic bladder, because we fill the bladder with contrast medium, we use fluoroscopy, and that will give you a lot of information about the shape of the bladder, whether the bladder contracts in a normal way, whether there is trabeculation, diverticular. You can see whether there is reflux. You can see what the effect of avoiding is on the reflux, or in general, increase in pressure in the bladder. And it also provides you good configuration of the urethra, the bladder neck, and the pelvic floor muscles. And that is extremely helpful in children with DSD. Because the EMG, the skin electrodes, don't pick up the relaxation of the internal sphincter. It only gives you information about the pelvic floor muscles. We use the fluoroscopy about every 30 mL of filling, and if the bladder has a normal or a higher volume, you can do it at every 50 mL. But also when there is increase in pressure, when there is reflux, you can do it more often. And anytime the child starts voiding or leak urine, you use it. You can nowadays use the memory function to limit the radiation time. And we have done a study in more than 3,000 patients where we did video urodynamics. And the average of radiation time was less than 1 minute per study. And that is that amount is less than one plain X-ray. And that is using fluoroscopy. This is not true if you also want to take pictures, but we use usually the fluoroscopy, and those pictures are stored in the patient file. You can use a video printer or any other kind of documentation is possible nowadays. We don't routinely use urethral pressure profiles in children because they are extremely difficult to interpret, and it cannot deliver reproducible quantification of urethral resistance or obstruction, and it cannot discern between anatomical or functional obstruction. So in children, this is not really recommended. 2 slides on ambulatory urodynamics. It's also called natural fill cystometry because the study lasts usually about 6 to 12 hours. We don't have to fill the bladder. The child can walk around and do normal activities. The disadvantage is that you have to put in the suprapubic catheter before starting the study. There is one rectal catheter, and we use skin electrodes. It is much more versatile than conventional urodynamics, but of course, because the child is moving, there's always a risk of losing your signals, especially the rectal catheter can easily become dislodged. It is also extremely time-consuming. It gives you a lot of additional information, especially when you're doing voiding studies, and during the conventional cystometry, the child does not want to void. Now, this is not true in patients with a neurogenic bladder. In general, ambulatory urodynamics is limited because therapeutic outcome is not influenced in the majority of cases. It's very time-consuming and therefore expensive, and it should only be used in selected cases and done by very experienced people. So for routine use, there is no indication. Urodynamic studies in children with MMC or any other kind of spinal dysraphism are extremely important for the management. But you have to realize that it is a non-physiological situation. Artifacts. It is not always reproducible, and it is part of the total diagnostic workup. And you have to treat the patient and not only a urodynamic abnormality. Thank you. And now I will hand over the microphone to Giovanni, because I can imagine that you may have some remarks or questions. Thank you again.
Thank you, Rien, for your fantastic presentation. Very, very clear. And I believe that many answers that we have received a correct answer during your presentation, and very didactic, very useful, and not easy to summarize all in so few minutes. And we received some questions and by the audience, and I would like to try to answer. And one question was related to the usefulness of the urethral profile and in children. And your answer is very clear. Is something that is on the knowledge, on the daily practice of the adult urology, but in children is not very useful in the majority of the case. Maybe could be useful in some patients, older patients that are adolescents, but very, very specific case. Regarding the normative value of the pressure of the bladder during the cystometry, if they're related to the age, and you was so clear in order to represent that the risk value above 40 centimeters of water are, of course, useful for children, for pediatric population too, but we have to remember that also value below, as you presented, could be at risk, and above 30, and a safe bladder in pediatric population is below 25. And regarding the what age of performing uroflowmetry is informative, is realistic. And first of all, we have to remember always that we have to repeat uroflowmetry in order to have something useful, and the suggestion of ICCS is to repeat for 3 times. And when to perform, and we have a daily continence, so normally the suggestion is to perform after the age of 3. Of course, we have to consider the single patients And in some cases, if we have, for example, mental delay, what we call children with special needs, also 3, 4, 5 years of age, we will perform a neuroflowmetry that will be not useful for our clinical evaluation. So never before the 3 years of age, but consider the single patients. There is a good question regarding in which impairment, in addition to neurogenic bladder, is a urodynamic useful. And of course, in all the major malformation of the lower urinary tract. And first of all, posterior rectal valves. We know that we have a high percentage of boys that we operate in a perfect way also, and removing the valves, but they present a bladder dysfunction during time. And for this group of patients, it's mandatory to perform during time urodynamic evaluation. Why? Because there is a high risk of bladder dysfunction, but this bladder dysfunction in many cases is the cause of the renal impairment, and we know that posterior rectal valves are children at risk for end-stage renal disease. Another group of patients that we have to consider to evaluate with urodynamics is the group of patients with bladder exstrophy or epispedia. In these patients, we know that we can close the bladder, but we will have a low volume bladder, and the bladder will be at risk for the upper urinary tract. And we have to treat continence in these patients during time to follow the continence. And we know that if we ameliorate the continence, there will be a risk for the bladder. And so it will be important to evaluate the bladder with urodynamics. Another group at risk that need urodynamic evaluation are patients with neurogenic and non-neurogenic bladder, Inman syndrome. Again, there is a risk for the bladder, but also for the upper urinary tract. And we know that we have to study these patients. Other group that need an evaluation are patients with bilateral reflux and or severe reflux, because we know that it's very important to evaluate if the reflux occurs at high pressure or low pressure. And there is a question about what to do when we fill the bladder during hydrodynamic, when to stop to filling if the reflux occurs. And the answer is that we have to study the bladder, and we don't have to fill the kidney. And of course, if we have the reflux, we have maybe to repeat the study, but we have to define when the reflux occurs, at which pressure. Another question is the preparation for children for urodynamics and timing for premedication. And this could be two different questions, and preparation of children for urodynamics. And we know that some patients are at a major risk for UTI. This means that we have to check the absence of UTI in all, and never to perform a urodynamic test if the UTI is present, also because there is a risk for pyelonephritis, but also because we will observe false data, because if there is a urinary tract infection, there is maybe an overactive bladder associated to the infection. Because we know that when we have infection, one of the first things that we will observe will be urinary incontinence due to the overactive bladder. And so the answer is to check the absence of UTI. If the answer if the UTI is present, we have to postpone the urodynamic test. If we have a population at risk of UTI, we have to start some days before, 3 days, the UTI prophylaxis, antibiotic prophylaxis. In some patients where we are sure that there is no risk for UTI and we have checked the absence of UTI, we can avoid the UTI, the antibiotic prophylaxis, and we can wash the bladder at the end of urodynamic evaluation, for example, with a gentle machine. And regarding the preparation of the patient, it's important to remember also that we have to measure the abdominal pressure. So it's important to have a clean rectum. If there is a severe constipation, as for patients with a neurogenic bladder that normally have also a neurogenic bladder, it's useful to clean the bowel and to perform enema or to perform transanal irrigation before, in order to have a better pressure evaluation of the abdomen. And we received other questions regarding in patients with autism. Is a very good question, because we have this group of patients when the children with autism are included, the children with special needs, and in these children to perform invasive tests could be very difficult, and in some cases, and could be useful. And this is a question for you, and Rien, about the usefulness of the suprapubic catheter, and when to use, when could be preferred to transurethral, and also how to evaluate the sphincter competency. And I don't know, Rien, if you would like to add something.
Yeah, well, you have answered a lot of questions already, Giovanni. Thank you for doing that. The question about autism is a very difficult one, and autism is a broad spectrum, so it's not the same for all the children that we call autistic. But I think it's a very good question, and in some of the patients with autism, a urodynamic investigation is usually not possible in the normal way. So you have to be very, very careful there, and you have to talk to the parents, you have to examine the child, see what is happening. And if you want to do any kind of investigation in a child with autism, you have to take more time and explain the child exactly what you are going to do, and usually repeat that a couple of times before you actually do the investigation. It is possible, but you have to be extremely careful, and you have to take time, do it together with the child, and you have to stop when it is absolutely not, when it looks like it's not going to be possible to do that. And you don't want to force anything on a child, and that is not only for children with autism, but also for children in general. The child has to understand why you're doing it and what you expect from the child. There was another question above that is, are there any absolute contraindications for urodynamic studies in children? Actually, there are not a lot of absolute contraindications, but there is a group of children that you suspect of maybe having had to suffer from sexual abuse or any other kind of abuse. And that is a group of children that you have to be absolutely very, very careful. And in most of the children that are known with a history of any kind of abuse, it is better to do the urodynamic studies in a different way, or don't do them at all. You have to be extremely careful, and otherwise there are very few absolute contraindications. There is another question. You had another question whether to use suprapubic catheters. when we still were doing ambulatory urodynamics, we always put in a suprapubic catheter, usually the day before we start doing the ambulatory investigations. And another group of patients that I find it very useful to put in a suprapubic catheter is the evaluation of children with a bladder exstrophy. Because introducing a transurethral catheter, especially in boys, but also in girls with bladder exstrophy, is sometimes very sensitive, it's painful, and then the result of the urodynamic studies is not going to be very much helpful, and it will not give you the answers that we were looking for. So in general, the children with bladder exstrophy, we put in a suprapubic catheter and under anesthesia, and then we do the urodynamic studies the following day, or at least when the child is fully awake and you can do a sensible urodynamic study. And otherwise, we usually only use transurethral catheters in the majority of our cases. And there was another question on the evaluation of sphincter competency. That is true both for the bladder exstrophy patients, but also, and the epispadias, of course, and also in patients with other anal rectal malformations or persistent cloacal malformations or whatever, but also in the neurogenic bladder, because if you put in a suprapubic, if you do studies in order to get an idea whether the bladder outlet is, and that is the sphincter mechanism, whether that's competent or not, it is very useful to use fluoroscopy as well, because you can fill the bladder, and then right from the beginning, you get an idea whether the bladder neck is closed during the first phase of the filling, as it should be closed, or whether it's completely open. And especially in some patients with a neurogenic bladder, you can see that the bladder neck is not contracting at all. And the only reason why some of these children can hold their urine is because they have a closed external sphincter, and you can see that on the fluoroscopy. The problem, in order to evaluate the internal sphincter by using EMG electrodes, that actually is not possible, because the signal that you measure with skin electrodes is extremely weak, and we need to amplify that signal significantly to make it visible. And if you really want to get a good impression about the contractility of the internal sphincter, some people have used needle electrodes to put them into the internal sphincter area, and that will give you some clue, but that means a very invasive procedure to get information from the internal sphincter. So we usually rely on fluoroscopy, and the advantage is that you have a clear image during filling, as well as the voiding phase, whether you have contractions of the internal or external sphincter, or whether there is a good relaxation at the same time the bladder contracts. And that is, you can have, I mean, I have many videos to show that, but that was a little bit out of the scope of my presentation, so I didn't do that. So I think fluoroscopy actually helps you a lot to evaluate the competency of the sphincter. In the severe neurogenic bladder, sometimes when the bladder has extremely high pressures, and you do want to do and consider a bladder augmentation, the question always is, do you need to do something about the bladder neck at the same time or not? And in many of the patients, just doing a bladder augmentation will make them dry, even though the internal sphincter may not be completely competent. But then in those cases, you don't need to do a bladder neck reconstruction or bladder neck plasty or whatever you want to do to increase outflow resistance. So I think I don't see any more questions, so I will give it back to you.
Thank you very much. Yeah, perfect. I totally agree with you, and very, very complete answer. We are in time to finish, and I would like to leave the podium for Dr. Zimak if you have any comments before.
Thank you, Professor Ryan, for this understanding presentation. Thank you, Professor Musiello, for active discussions and comments here and answered questions. Remaining questions will be answered and show on at the beginning of next webinar, and it will be available at the ERN websites at the same. For our Ukraine, and I would like to say thank you our audience for active participation with questions. Шановні колеги, як вже говорилось, відповіді на ці питання ви зможете так само переглянути на вебсайті, і відповіді на них будуть озвучені на початку наступного вебінару. Thank you once more.
Thank you all. Goodbye and stay safe.
Я ще хочу зробити невеличкий анонс наступного нашого вебінару. Він буде присвячений темі його лікування інфекцій сечовивідних шляхів і міхурово-сечовідного рефлюксу. Чекаємо вас всіх, і ми сподіваємося, що у нас уже дуже гарне товариство зацікавлено проблемами спінальних дизрафізмів. До зустрічі. Дякуємо ще раз нашим шановним спікерам. Thank you very much for our speakers and all participants. До зустрічі на наступному вебінарі.
Very much again, and see you on the 22nd of February with a webinar on the urinary tract infection and vesico-ureteral reflux management. We will have with us Professor Giovanni Montini, nephrologist from the University of Milan, and Professor Raimund Stein for the University of Mannheim, Germany, and nephrologist and pediatric urologist. We will have this face-to-face about urinary tract infection and vesico-ureteral management, and from two different points of view. I suppose that will be very interesting. Thanks to all for the participation, for your presence, to Professor Rien Nijman, for Dr. Natalia Zimak, and for all the participants. And of course, thanks to EUROGEN, to International Federation of Spina Bifida, and to OMNI-NET for organizing this webinar. Thank you, and see you again on the 22nd. Bye.
Bye.
Bye-bye.